The second part of the talk, the pro, will be presented by Professor Waleed Masoud, consultant of nephrology, Ahmed Maher Teaching Hospital.
Mr. Chairman, thank you. Okay, since I was a young doctor, I've always learned that dialysis to patients with hepatorenal syndrome is always useless and futile. It all started in 1975, but very disappointing results of a report involving 25 patients with cirrhosis and acute kidney injury. The in-hospital mortality was 100%. Next. Oh, the أنا zero. Okay. Well, now when you read this paper carefully, you'll find that the report included few patients, 11 with hepatorenal syndrome and 10 patients with hepatorenal syndrome and 11 with acute tubular necrosis. The second point is that most patients in this study were treated by peritoneal dialysis rather than hemodialysis. And in common practice nowadays, acute kidney injury is either we use chronic continuous renal replacement therapy or hemodialysis. A more recent study to challenge the concept of worse outcomes with hepatorenal syndrome by Allegretti et al. Dated 2018, involving around 500 patients with cirrhosis and acute kidney injury who underwent their dialysis. The mortality rate between patients with pure hepatorenal syndrome and acute tubular necrosis was almost the same. One is 84% for HRS, and ATN was 85%. So my first argument would be hepatorenal syndrome patients requiring dialysis carries high mortality. That is why we don't dialyze them. But on the other cases with acute kidney injury and liver cirrhosis also carries a high mortality, and yet we dialyze them readily. The diagnosis of hepatorenal syndrome includes several criteria. By all means, I will not be able to run through them because I only have 9 minutes to finish this talk. But these criteria are by all means not accurate. There are many pitfalls. And I've ran into 3 studies assessing the accuracy of diagnosis of hepatorenal syndrome. One showed 59% rate, the other 37%, and the last one showed only 21% accuracy for diagnosis of hepatorenal syndrome. Again, I want to stress that it's not always hepatorenal syndrome alone. As Professor Omara explained, that it runs into several metabolic pathways until at the end the main event of hepatorenal syndrome is intrarenal vasoconstriction. Now let's take these stages. Long before acute kidney injury occurs, the kidney already has a high resistive index due to the liver dysfunction. It becomes more vulnerable to injury by other factors like hypovolemia, infections, bile acids, nephrotoxic medications. At this stage, a minor insult may cause severe injury to this predisposed kidney without the actual development of hepatorenal syndrome. Thus, patients with pure hepatorenal syndrome might constitute only a subset of patients who have kidney dysfunction, while the remaining patients have both hepatorenal syndrome and other causes of acute kidney injury. And therefore, my second argument would be, I cannot take a life-ending decision simply kida, with the lack of a gold standard test for diagnosis of hepatorenal syndrome. Now, my other point is dialysis for hepatorenal syndrome hopeless tamaman kida yani? Well, there is not enough publications. Why? Because it is condemned, it seems, to dialyze patients with hepatorenal syndrome. There is not enough data to evaluate the effect of dialysis on these patients. However, there is a descriptive study involving 27 patients, not much. The 1-year survival rate patients who received acute hemodialysis when they have liver cirrhosis, hepatorenal syndrome, was 28%, compared with what? Compared with 2% only for those patients with acute kidney injury who were not dialyzed, although it was indicated. So definitely, dialysis to hepatorenal syndrome is not that hopeless. So my third argument would be, it seems dialysis is not as futile or hopeless as anticipated. Now, what's our decision? Like Professor Omar said, I will distribute these patients into 4 categories. The first category we all know and we all agree about, that patients who are enlisted for liver transplant, of course, I have to make dialysis. But if liver transplantation is not set on, I will name these patients as patients likely to benefit for liver transplantation. Personally, one should lean forward to offering them dialysis until a clear settlement is made. هعمل له liver transplantation ولا مش هعمل له, etc. Now, what about the patients who are ineligible for liver transplantation? These patients typically are critically ill, acute kidney injury, multi-organ dysfunction, and intensive care units. Here, I have to look for the terminal signs, which is mechanical ventilation, vasopressor support, coma, dependence of CRRT with no kidney benefit. I believe that performing dialysis would be useless. And the last category, in the absence of solid premortal elements, as I call them, I suggest confronting the family to understand the patient's wishes. Explain that maintenance of life by virtue of dialysis for additional weeks or months may not provide comfort to the patient. In fact, it may increase their suffering. Well, for many patients and their families, extra days, weeks, or months can be very meaningful. While others say prolonging the inevitable is not an option. Thank you very much.
Thank you, Dr. Waleed. Thank you so much.
Wait. Just a comment on this. Provided in the hepatorenal syndrome is a correct diagnosis, I think withhold is better than withdraw. يعني مفيش داعي ان احنا نبتدي نعمل داياليسيس طالما شخصنا فعلا هيباتورينال سندروم. withhold is better than withdraw. مفيش داعي ان انا ابتدي اعمل داياليسيس وبعد شويه اقول لا احنا هنوقف الداياليسيس.
First of all, I have to answer that there is no gold standard for the diagnosis of pure hepatorenal syndrome. And most of the time, you have a combination between hepatorenal syndrome and other causes for acute tubular necrosis. وانت سعادتك يا فندم لو جالك حاله وعندها liver cirrhosis and you are sure ان هي acute tubular necrosis, you will definitely dialyze it. طب اشمعنى بقى تاني؟
انا بتكلم على اساس ان انا بروفايدد ان انا شخصت تمام العيان ده ايوفوليميك، مفيش نيفروتوكسيك، مفيش urinary tract infection، وشخصت ان هو هيباتورينال سندروم ومفيش بلان ان احنا هنعمل ليفر ترانسبلانت. No point. It's better to withhold, and sometimes hardest truth are most worth telling. ان انت تقول للنكست كين والله بص اشرح له الموضوع وتقول له وما تبتديش اساسا ان انت تعمل ده. بس ده بروفايدد ان انت ده كوريكت
يعني you're saying ending of life, خلاص, and you're not sure of the diagnosis, number one. Number two, dialysis is not as so bad as we anticipate. Number three, it's not your decision, it's the decision of the patient and the family. أنا عايزه يعيش، عليه ديون عايز يدفعها، عايز يصلي ركعتين قبل ما يموت، أي حاجة يعني. ما
أنت زي
أحبك عظم كده جامد.
زي ما قلت ان ده هيبقى سفرنج للبيشنت وبتزود السفرنج للفاميلي فاينانشالي وايموشنالي واكزهوشن للريسورسز. انا بقعد اعمل CRRT مثلا اسبوع 10 ايام، ده اكزهوشن للريسورسز.
بص it's a debate but again خلاص it is their decision, it's not ours. Our decision is to offer better quality of life. but not to end it. So انا قلت لو كوما، لو على سيفير فازوبريسرز، لو على then اوكي خلاص بقى. انما لو ما بين البنين وهو معظم عينينا كده يا دكتور ايمن، لازم تديهم فرصه يعني للاهل يقولوا اه او لا.
طبعا دكتور صبري اتفضل.
هو ده اللي انا كنت خايف منه. تعالى معايا يا دكتور احمد.
لا هو بس النقطة في الموضوع إن تعريف الهيباتورينال سندروم بروبر هيباتورينال سندروم إنه advanced liver disease producing acute kidney injury without parenchymatous changes, without anatomical changes, just physiological disturbance of the function of the kidney. لأن يعني decreased blood flow, renal blood flow, vasoconstriction and so on. We should exclude from this category إذا كنا هنفكر في حكاية الدياليسيس those patients with acute liver disease. هو لما قال في التعريف قال advanced liver disease ما قالش whether acute، ما حددش acute or chronic. الكرونيك اللي هو advanced cirrhosis طبعا ده hopeless، الليفر مش هيتحسن وبالتالي الكدني فانكشن مش هيتحسن. لكن في some cases of acute of hepatorenal syndrome secondary to acute liver injury. hepatitis ايا كان سببه، اذا كان فيرال، اذا كان drug induced and so on. These acute insults of the liver are vulnerable for reversibility. وفي هذه الحالة we should support them if they have acute, if they have hepatorenal syndrome, we should support their lives until this acute injury of the liver is.
ما اختلفناش في ده يا دكتور صبري، احنا اتكلمنا على اساس ان انا اوكي انا I'm sure from correct diagnosis انها hepatorenal syndrome type 1.
ما هي دي diagnosis، ده true diagnosis and correct diagnosis of hepatorenal syndrome ان هو advanced liver disease.
ده انا مش
كلمة advanced لا تعني chronic. It may be chronic and it may be
لا احنا
acute.
بنتكلم على الكرونيك اللي هي الادفانسد اللي هي تايب 1
لا احنا بنتكلم
hepatorenal
بقى،
syndrome type 1.
احنا بنتكلم as a whole. advanced liver disease
لو في حاجه ريفرسبل،
and may be
لو حاجه ريفرسبل طبعا هنسبورت البيشنت. لو حاجه irreversible يبقى نو بوينت.
I think برضه حتى في الحالات اللي هنا بنشخصها تايب 1 ويند ستيج hepatorenal syndrome I think that we should exclude all the possibilities of being irreversible.
ما اختلفناش، ما هو ده كوريكت
دايجنوستس. في الحالات اللي زي
دي طب ممكن انا اسال البانل سؤال؟
اي ريكومند بس في الحالات اللي زي دي ان انا اعمل جاست اكسبانشن اوف ذا بلازما فوليوم على قد ما اقدر. اذا حسنت الفانكشن اوكي ويل اند جود، اذا ما حسنتش خلاص.
ممكن اسال انا البانل سؤال؟
لا احنا
وايفن الاودينس قبل ما نمشي.
we have to cut
anybody of you working had to once dialyze hepatorenal syndrome لأسباب تانية غير اللي انتوا بتقولوها؟
أسباب سياسية بس.
طب خلاص ما يبقى احنا بنتكلم صح اهو.
Thank you. Wait please, there is a gift from the Egyptian Society of Nephrology for its 40th anniversary for both speakers.